Good afternoon and welcome to HealthSystemCIO.com's All-Star Panel, Readying Your Organization for a Value-Based World, a webinar tweet chat combo from HealthSystemCIO.com sponsored by Geneia. Just a little bit of housekeeping before we get started. My name is Anthony Guerra and I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We are hosting a tweet chat, simultaneous tweet chat, which is hosted by Kate Gamble, our Managing Editor and Director of Social Media. And you can participate in a separate browser or on your phone by using the hashtag HSCIOchat. Or if you want to just view the tweet chat, you can look in the Media Viewer panel on the right-hand side of your screen. Other WebEx panels we'll be using will be the Q&A panel today. You can use that to submit your questions at any time. In the Q&A panel, in the lower right-hand corner of your screen, keep the default set to all panelists. You can send those in as they occur to you, and we will take them later in the program. And you can download the deck using the URL on your screen. It's at the bottom of, shortened URL for it is at the bottom of your slides, and also it'll be sent out in the chat box, so lots of chances to get the URL. Just so you see how we are going to spend our time today, we're going to go 35 or so minutes with our panel discussion featuring Kyle Johnson, SVP and CIO at Eastern Maine Healthcare System, Michael Elley, System VP of IT at OhioHealth, Renee Broadbent, AVP Population Health IT and Strategy, UMass Memorial Medical Center, and Fred Rahmanian, CTO at Geneia. So without further delay, we are going to jump right in. Kyle, can you give us an overview of your organization, please?
Sure, and thank you, Anthony. So Eastern Maine Healthcare System is located in mid-state in Maine. We're, yes, for those of you familiar with the coast, we're, within half hour, 45 minutes of Bar Harbor, Maine, so we're that part of the state. We're a 9 healthcare system or hospital organization with, many ambulatory, home care, and facilities throughout the state. We actually span the most northern tip all the way down to the south in Portland, so we have a wide geography. We're pretty rural state, and a population that really is staying stable but not growing, about 1.4 million people in the whole state of Maine. So there's just some idea about what we're dealing with. And probably 80% of our payer mix is government payers. So, so we just have a small, commercial portion of our business.
Very good. Michael?
Yes, thank you for having me today. Michael Elley with OhioHealth. We are a 11-hospital system based out of Columbus, Ohio, servicing most of Central Ohio. So about $3.5 billion annual revenue. Again, 11 hospitals, about 725 physicians, and 375 advanced practitioners.
Very good. Very good. Renee?
Yes, thank you. Renee Broadbent, AVP for Population Health IT at UMass. UMass Memorial Healthcare is the largest healthcare system in Central Mass, and we're also a clinical partner of UMass Medical School. We're located in the central part of the state, for those of you who aren't familiar with the state of Massachusetts. We have about 1,600 physicians on our active medical staff. We have about 3,000 registered nurses and a total of about 12,000 employees. Our hospitals have about 1,125 beds total. The health system includes UMass Memorial Medical Center, Clinton Hospital, which serves the Clinton, Mass area, Health Alliance Hospital, which serves Leominster and Fitchburg, and Marlborough Hospital, which serves the Marlborough area, and we are one integrated delivery system. In addition, we have multiple federally qualified health centers, as well as a large and growing, and the biggest part of our growing, independent practice network.
Very good. And Fred, a little bit about Geneia.
Yes, thank you, Anthony. Geneia is a healthcare analytic company. We're based in central PA in Harrisburg, Pennsylvania. We also have offices in Manchester, New Hampshire. And we specialize in development of advanced clinical and technical solutions to assist our customers with the healthcare transformation. Using our advanced analytic platform and remote patient monitoring tool and education and research institutes, we work with healthcare organizations to improve outcome, lower cost, and of course do what we call restore the joy of medicine.
Very good, very good. All right, Fred, let's stick with you on this. What steps have you taken to position your organization to operate in a value-based environment, or let's say to support your customers and healthcare organizations?
Yeah, so I think that the interesting thing about the value-based environment when we go from fee-based is that the risk is shifting now. So what we see is, so I think it's important for helping providers understand where the risks are and how to manage those risks. So we help our customers identify risks and mitigate those risks. And in a value-based environment, when you think about it, patients are your greatest risks. That's where we talk about maintaining the health of the patient, and that's where we come in, and we help our customers with that. We allow them to identify and how to focus, where to focus on their patient population to improve the health of the patient and their population in general, and hopefully that will help them mitigate the risk.
Very good. Renee, let's go to you. Same question. Steps you've taken to position UMass for value-based care.
So from our perspective, we see this as having to be part of the overall organizational strategy so that you can achieve buy-in in all levels. And it's obviously a constant work in progress. So we have built it into the organizational 2020 vision. It's actually a line item in there to move to value-based care. And this has helped us to build the governance and the support and the processes around that. Because at this point, you want the endorsement from your most senior level executives, including the board. In addition, we've created an internal organizational infrastructure to support just a focused effort on value-based care and population health. And that's the entity that I'm currently working within. And we have a dedicated team of resources of all types that we've built on this team, including physicians, operational activities, information technology, analytics, care management, financial and compliance and legal. So, I mean, we have individuals whose job it is to just really monitor the things going on with MACRA and all that. And also, we look to build our network structure. So while we have a lot of own physician practices, we've built a very large independent network, and we continue to grow that. In addition, we've developed a defined strategy, and in that strategy, we define what programs will help us manage to that environment. So, for example, what tools, what instruments are you going to use, such as an MSSP, self-insured, et cetera. Before we got started, we conducted a value-based readiness assessment, and some of that was done internally, and some of that we used some external resources to help us perform that function, and inventoried our current technical capabilities because there's a lot of shift and changes in our systems that have to take place. And in addition, part of my job was to create and work with the business units to create the technical frameworks. What systems are we going to be used? And a key to that is really, and when you're trying to understand your readiness, is what other organizational efforts are going to have impact on your ability to achieve all of this. And for us, and I'm sure many people on the line can relate to this, we are installing Epic in our entire health system as of October 1st of next year. So that has significant impact too. And I think one of the other things that we've done very, very well in our organization is creating an educational strategy, because what we find a lot is there's misconceptions or lack of understanding, among various groups of folks, including our clinicians, and including those we're trying to integrate into our network.
Excellent, very good. Michael?
So a lot of similarity, I think, between Renee's organization and mine. It's interesting. Within Ohio, we haven't seen really a drastic change to reimbursement, but we do see it coming down the pike. Just when that hits us is still a question. So what the organization has done is started an initiative probably about 7 to 9 months ago called Quality and Affordability, in which we identified 16 different areas of our organization in which we knew that we wanted to look at to see how we can operate better within a value-based world. So we looked at some clinical areas such as behavioral health or end-of-life care, obstetrics, those sort of things, either from how do we perform better from a quality, not a quality perspective so much, but how do we reduce those costs in those areas? We know the end-of-life care has a high cost to both the individual, the payers, and the hospital. So what can we do better to drive down those costs? But also, what from a value or from a volume perspective, can we increase our market around? Because a lot of this is really a volume grab, because you want to, while we're going to be seeing a reduction in our reimbursement, so that means we need to grow our volumes correctly and wisely. So then we started looking at other areas like our, an enterprise project management office, span of control, supply chains, those sort of things that aren't so clinically driven, but there's still areas of the organization which we have opportunity to potentially improve and have savings or kind of shift our way of thinking of how we're managing today's environment. So that's been a tremendous initiative that's been going on in the organization for the past 3 quarters, basically. We're also trying to really get a handle around, we're self-insured, and get a handle around our PMPM costs. And I'll go back to my volume comment from earlier is we can show that we are driving down our PMPM costs among our own associates, our own employees. Then we have an insurance product that we can take out to the market and start targeting employers within our area and providing services to them and showing, hey, have those conversations with them and say, what are your pain points with your own employees? We can show you, here's what we've done with our own employees, our own associates, and how we've been able to drive down costs and again, grow the volume that way, but also decrease the cost to the consumer.
Very good. Kyle?
Yes, so at Eastern Maine Healthcare Systems, we started an ACO, Accountable Care Organization, over 5 years ago, and began that organization with Medicare Pioneer, and we're managing those patients and our employees, at that time. And actually the employees we've been managing for probably more like 7 or 8 years, so this organization really started with that population. Today we have, maybe 150,000, 180,000, somewhere in there, covered lives in the ACO. We have, 5, 6, 7 commercial, groups besides the Pioneer, which has now moved to Next Gen, and we have, entered into the Next Gen Medicare program. So we are actually taking risk. Most of our commercial products are, somewhere to partial to full risk. And we're really seeing the reimbursement changes in our neck of the woods. Having said that, though, there still is plenty of fee-for-service happening. So really, straddling both of those, reimbursement perspectives as it continues to move towards value is really a challenge, and it's really like talking out of both sides of your mouth, because, really on the population health side, you're trying to, limit the, or reduce the amount of, high dollar imaging, costs and other things like that, whereas, on the fee-for-service side, the more volume you can pump through, the more you make against those contracts. So it really is a little bit of talking out of both sides of your mouth, and we're finding, that an interesting challenge to partake. We are also in the midst of an EMR search and selection, and I raise this because I think, all of these things are, and we're thinking about this whole continuum of moving to value-based care as, digitizing, the healthcare system and really becoming more, consumer centric, and all of those things are, aimed at, providing better care, lowering cost, and, which is part of the triple aim, so.
Renee, I think I heard you chuckle. Do you want to comment on that?
No, I was just listening to it. I'm just listening to what everybody's saying. We're kind of all, struggling with the same thing, especially, when you look at other organizational initiatives, such as putting in a new EMR and trying to manage all of these things and get that delivered as well. So,
lots on your plates for sure.
Mm-hmm.
All right, Renee, actually, let's start with you on the next question. What technologies have been involved in this transition? Talk about the concept of data granularity, data integrity, and data governance.
So what we tried to focus on is creating a framework of those things that would be important to, or what are the foundations of value-based care, population health, et cetera. And we've identified the key components and systems that you're going to need to support are things such as data aggregation, collecting data from lots of different sources and using that data in a meaningful way, care management, and of course analytics and reporting. We also have identified, because we have a fairly large network that extends beyond the health system, that we needed some sort of network communication to our participants. And so we have utilized, from a system level perspective, a CRM to do that, which is not often thought about from a, you think of CRMs in commercial business versus healthcare. It's a little bit different, although I'm noting a lot of health systems that I'm talking to are also deploying it. So we use that as our method of communication to conduct webinars and reach out. So we also went through an effort. One of the things, and looking at, what Kyle has done, we had a lot of fragmented information in databases. And so we have taken the steps between EPIC as well as other efforts to streamline data so that we have sources of truth that are, accurate and reportable. And one of our key pieces is, because we have data from different sources that mean different things, we identified and are employing a data aggregation tool. That tool will go out and it gathers information from all of our participant EMRs and our managed care network and our accountable care organization. And we have roughly about 350,000 lives between the two that we're managing, and that's continuing to grow. And there's lots of different systems and entities out there that we need to get data from. And we have an analytics solution that we are using for quality reporting, TME, and predictive analytics to help our care manage those population as well as the rising risk. And we put teams in place, including data integrity teams that look at this, that make sure the data is validated and scrubbed, coming from these sources and normalized so that what we're reporting out is actually accurate, discrete, and usable. And we're in the process right now, because we are, in the process of going to EPIC and moving the organization in that direction. We are establishing a system-wide data governance, because as you know, in a large integrated network, and as things come together, everybody has their own idea of what data analytics is and has different business needs. So we're creating a system-level strategy around data governance. And I'll just finish off with one thing. In my experience and opinion, that population health isn't going to be 20 million tools that you need to manage your population, but it isn't one tool either. I think that there's a suite of things that you have to be considerate of that will help, that you can integrate, that will help manage your environment. And I think if you focus on the data, the reporting, and the analytics and care management, you'll get all of those pieces that you need to actually effectively manage the populations.
Excellent. Thank you for that. Fred, you want to talk a little bit about the technologies involved?
Yeah, I think actually I was very interested in hearing what Renee talked about just now. I think a lot of those things are very important. Given my background, I firmly believe the majority of the issues or challenges we have in healthcare we can solve with the right amount of data. And as we've seen in the past, there's a gluttony of data that's coming on. Even the iPhone you carry has like somewhere around 12 sensors in it. That some of that information could be useful in managing care for your patients. The other thing that's very important is what I heard was that people are working very hard in collecting a lot of information from different sources within the organization. in a very effective care management environment, as well as ACO the contracts that are out there, it's not enough to know what happened to a patient inside your organization. It's also very important to understand what happens to your patients outside of your organization. So getting that data and bringing that in and synthesizing it, and then essentially doing that semantic normalization of the data, because as we know, healthcare data is very local, and everyone's got their own set of codes and their own way of interpreting the data. Being able to bring all that information together in one place and put it in what I call actually a patient-centered repository, not so much, a person-centered repository, not so much a patient-centered repository, is very important. So we all want that we're all chasing that unicorn, the longitudinal view of a patient's health information, but it's not a very easy thing to do, and it's not just enough. It's not enough to know, collect your data. You need to be able and be ready to collect other information from other sources outside of your organization. So, in our organization, so one of the things we provide, in addition to aggregating all of that data and the semantic normalization and harmonizations and the ontology work that we do, we also, provide the ability to capture information from sources from, your healthy patients. Why not learn from what keeps a patient healthy rather than trying to predict from why a patient is going to be readmitted within 30 days, and granted that's an example everybody uses, using unhealthy patients. So it's very important to keep that in mind. It's, I'm a firm believer that, there's no piece of data that's not good data. Whatever we see today that may look like noise, it's probably going to be signal tomorrow. So having said that, it's very important, and I was very interested to hear all the measures that the other panelists have in place. It's, it's very important to have the right governance. So, but before you can have the right governance in place, you need to do a full inventory of your sources and where's the data coming from, and what does it contain, and how do we manage. And after all, the Spider-Man was famous for this, right? In the movie, with great power comes great responsibility. So we have all this data that we receive that gives us great power, but we also have to be responsible in terms of how we manage it. This is, after all, is PHI. So all of that is very important, and I think that's something that every organization should consider. And at Geneia, we take all that into account when we work with our customers.
So this is Renee. I'd like to just follow up on one thing that Fred mentioned regarding the data, and that is, taking data from multiple sources. My background is I'm also an information security officer, so I'm very cognizant of, protection of, people's personal health information. And I think when organizations are going down this road, you have to be really careful about your consent layers and things like that, because they vary with state and county and federal. Sometimes you can have conflicts with federal versus state in terms of what data you can access in terms of, gathering that information to help manage those populations. Our most effective strategy on that is to put that governance as well as that panel or board, whatever you want to call it, working group together to actually examine those issues and create the necessary documentation, and system structure to ensure that you're in compliance.
Right, absolutely, yep.
Very good. Kyle, you want to comment on the discussion?
Sure. I think there's a whole plethora of, technologies needed for getting to value-based care, and they probably fall in different buckets. So, for population health, it's registries, it's care management tools, it's claim-based analytics, and probably, tools that help you really manage your, your managed care network, if you will. And there is no panacea out there of anybody who's built all of those capabilities together in a single tool. A lot of folks are touting this, but haven't seen it yet. And, some tools do a couple of those things really well, but generally not all of them will do all things yet. So something to kind of watch in the marketplace, which means providers have to, cobble some different things together in that space. And I think more broadly for the health system, I think the technology landscape is really changing, and I talked about digital transformation, and part of that is that I think, you know, as technologists, we have to think about simplifying the environment, you know, putting more things and trusting more things in the cloud so that we're able to, you know, do and be more things, you know, to the organization, because as we enter this consumerization phase, if you will, it's really, it's different work than, you know, we've encountered, you know, thus far in healthcare. And so I think we have to look at all the things that are available for us, and I'm constantly thinking about, you know, how do we simplify the environment so that we're able to give, you know, the most value to the organization as it's really trying to make this, you know, monumental shift right now.
Michael, want to jump in?
Yeah, I mean, there's a lot of great comments. First, though, Renee, I totally understand why the move from a CISO to overpopulation health CISO is so stressed. All this stress. All this pop health stuff is fun. So, no, I think that's funny. But no, I like what Fred talked about, and that's something we're facing today. He was talking about the longitudinal view, and our EMRs today do a great job of a vertical view of the patient. But where we really struggle and where we need to get to is that horizontal view across the business of how we identify who our patients are and how we're managing those patients. So we're working in that vein right now to do that. Also, I thought Renee also brought a good point around the CRM. That's something I hadn't thought. But yeah, we're looking at that, and I spoke about volume earlier. We're growing our network. Yep. So, but there's all these engagement points across the organization on the physician side, the hospital side. We're extending our EMR to private physicians and private docs, our reference labs, I mean, all those sort of things. So those CRM tools, I think, are becoming more and more prevalent within health systems, too, to help manage that. But then we're also looking at, you know, different ways of managing the data. So looking to, you know, the data lake philosophy and how we manage the data that way, utilizing and then, you know, tying that into Hadoop, and then data visualization tools on top of that, like a, you know, Tableau, Click, or whatever, to manage that versus kind of the traditional EDW. I think, you know, we are looking at how do we transition that way. We're looking at the predictive stuff because we're trying to get ahead of these things. But I think one of the things that we're also doing is from a digital mobile strategy. So how easy are we making it for our consumers to access us, to engage with us? And so we have a very large push and development around our mobile strategy with our consumers and with our patients. And it's funny, we don't refer them to so much as patients anymore. We refer to them as consumers, consumers of our healthcare services. So there's a lot of things happening within that mobile environment. And I think Fred was right around the governance. The technology side isn't so hard. It's the engagement of the operational areas along this journey. For example, you'll get a question and say, well, I don't know the answer to that from an operational side. And on the analytics IT side, well, we have that data. You just never asked me for it. And it's like, well, I don't know what to ask for. And so there's that translation gap that occurs. And I think there needs to be better alignment across the analytics, IT, and on the operational areas around that to get better insight into all that data.
Very
good.
good.
Kyle, I'd like to.
Yeah, go ahead. I'll add to that after that.
Kyle, who's that? Kyle?
Kyle, yeah.
Go ahead, jump right in.
I was going to add a little bit more to what Mike said about the data pieces. I think absolutely right. I think analytics and data is going to be key to running, you know, the business. And I oftentimes when I talk about this in talks will say, you know, I liken it to, you know, Ford Motor Company and Amazon, who refer to themselves as information management companies. And I think that's what we have to become in healthcare as well. And then speaking to the workforce that Mike was alluding to, you know, and that much of this has to be driven by the operational units. I think we have a workforce that's, you know, also not trained or maybe undertrained in, you know, in developing and using analytics. So there's a huge educational component to bringing, the industry and the workforce along in these endeavors.
Fred, I think you wanted to comment?
Yeah, I had two comments. I think originally Kyle mentioned something about the technology itself, and I fully agree. I think, at the end of the day, we don't want technology to get in the way of letting clinicians do what they do best. I mean, we should be in a supporting role, and I agree with that 100%. And at Geneia, we have this thing we call Joy of Medicine is we want the system to help the clinicians go back to what they love to do, not so much spend time in front of the computer, but more in front of the patients. So I agree with that 100%. But the other point I want to make about the data is also what's important, and this is with regards to what Michael said, and I agree with what he said, is the timeliness of data. So it's also very important for us to get this data and put it in the right place and put it in the right hands at the right time. The one thing, there was a mention of the EDWs. The EDW is still very useful, and we still have a place for it. And but the problem with those, the traditional business intelligence workflow was that by the time the data came into EDW, that ship has sailed, right? I mean, but yet I can see, okay, in the last 30 days I had this many, discharges with CHF. What I want to know is, what do I need to do? I want to be a little more predictive, and then of course this is what everybody talks about. I want to be more prescriptive about this data. So I want to get that data into my system as soon as possible, and create insight from that data as fast as I can, so I can actually take actions. And that's where, again, is another one of those things that everybody talks about, but not a whole lot of people have been able to accomplish. And there's a lot of work being done there, and that's very important.
Very good. All right. Next question. What is the low-hanging fruit in moving to a value-based environment? Kyle, let's start with you. Looking for things that, the smaller health systems, those that maybe don't have so much money to throw around, what are sort of the quick wins that you can get when you want to move down this road?
Yeah, thank you, Anthony. Well, I think, and, I've been with Eastern Maine for about 3 years, and I think, having walked into this organization, when I did, I found, we had started an ACO, and basically we're doing most of it on, with pencil and paper. So really running care management without, automated systems, registries not, nearly as automated, as they could be. And, and I was sort of astounded at how well we were doing, and we had a third party outside group that was helping us with some of the analytics around utilization and PMPM, and we are actually doing, quite well. So what I would say to folks is kind of get started, and it sounds like this group is certainly, doing that, but I think you have to, dip your toe into this water, and even if, your reimbursements aren't changing, it's important to understand how to manage and shift the mindsets for managing in a value-based environment, and getting started sooner rather than later is important. I think another piece is telemedicine, and I think there are ways to get started with that with technologies that you probably already have in place. We do telepsych visits in our state. We have a shortage of psychiatrists, which I know a lot of places do, and so we have psychiatrists around the country that do patient visits and consults for us in the state of Maine. And what we do, we send them a laptop, that's secure, and they come in to our network and then use our internal video capability to do video consults with patients who are able to do it on their mobile devices. So there are easy, quick, and inexpensive ways to, get started down this path.
Very good. Michael?
So I think it's the low-hanging fruit question. I struggle with that. I think there's wise things to do, and if you have an engaged medical staff, you can do them. But to me, they're around standardization. So standardizing on your supplies for your procedural areas or wherever, standardizing on your care delivery. Those, I mean, in the most simplistic form, and again, that's not low-hanging fruit because that's a haul. That's a lot of hard work to do, but there is tremendous value. And if you have that sort of engaged medical staff that understands the why and is willing to carry that flag for you, that's where I see a tremendous amount of, that's where I see a great first start.
Renee, is there low-hanging fruit in here, or is it just it's all hard work?
Well, I don't necessarily, it's always hard work, but I think, you know, just to reflect a little bit about what Kyle said, you know, ACOs, especially the track ones, are a good way to stick your toe in the water. You know, in a previous life, you know, I worked a lot in this environment where, you know, the physician lead was always very adamant about this is all about behavior change. And so, you know, when you're trying to transition from a fee-for-service to a value-based environment, you've got to have everybody engaged, and you've got to readjust behaviors. And that takes a lot. And the ACO, you know, is not an easy, but one way to actually start to modify those behaviors and understand the value that it brings by giving a different delivery of care. And, you know, you can, you know, I don't think that anybody's really unusual. We're advancing in a lot of places, but, you know, we still have some gaps as well in the care management area and, you know, the types of delivery and, you know, the paper and pencil type thing, and we're improving every day. But, I mean, certainly, you know, an ACO, to get people engaged and have them become more educated and, you know, get used to behaving differently, I think is a great way to go.
Very good. Fred?
Yeah, actually, a couple of comments. My view is from actually I come from the other side because not being a provider, I look at what can we do to help providers in this value-based environment. So, and the interesting thing is things that were low-hanging fruit and were not low-hanging fruit a few years ago have become low-hanging fruit now. There are some things we couldn't do just 3-4 years ago that we can do today to help, you know, move the needle when it comes to value-based environment. And some of that is, for instance, you know, our ability to identify patients as soon as patients that are at risk or could be at risk as soon as possible. I mean, that's the, you know, you want to know that risk as soon as you can, so you can actually prevent that and from happening. And the interesting thing there is, you know, they had a research at Google said, you know, our algorithms haven't gotten much better in the last 10, 15 years. What happens is we have a lot more data now. And I think that's what's happened. With our ability to capture a lot of data and a lot of information, you know, these things have become much easier to do. You know, a 30-day readmission risk 5 years ago, you know, what we had like Charleston Index that everybody used, and now, you know, there are probably 100 different papers published on how to calculate readmission risk for patients. So we're getting better at that. So along the same line, you know, we're talking about identifying at-risk patients, and then look at the same data and identify the treatment patterns. You know, what works best for this group of patients, or these patients that I just identified that need more attention. And then at the end of the day, it all comes down to using data to create new insight about the patient population. It may not be all about patients that are at risk. It may be just how can I engage this patient more effectively so I can help them stay healthy. And that works for the healthy patients as well. So, you know, what are they doing well that I can actually use? I can identify that and then apply that to my other people in the population that I have. So that's the nice thing about it, and we can do all of these today. And going back to what Kyle said, for instance, the telemedicine is actually a great example of something that we can do today that we couldn't do maybe 5 years ago, cost effectively. And then we're doing that today. For instance, there's also the other side of it is remote monitoring. We're doing that, and we're doing it effectively, and we've seen great savings there. Those are all can be you know, the low-hanging fruit in this new value-based world.
Very good. Well, our next question is sort of the flip side of the last question, the most difficult part. So, Renee, your thoughts on that? What's the really hard stuff here?
I think that in general, the lack of understanding from people in general about what this really means and different interpretations of it, and also kind of deciding what your portfolio is going to be in terms of the organization moving to value. So are you going to do an ACO? Which track are you going to do? Are you going to do self-insured? And, you know, APMs. I mean, there's a combination of different things that you have to do in deciding the right way to do it, I think, and get that out there to your constituents is a tough piece. I also think that with a lot of the changes that have gone on over the last 10 years or so between EMRs and the regulatory changes and HIPAA, we have a lot of physician fatigue with all the changes. I mean, it's one thing after another, and I think that, you know, we've really got to engage our physicians, and I think that there's a lot of fatigue out there with all these changes. And, of course, you know, MACRA recently was just finalized, sort of, and so trying to understand that and what that means and how that impacts, you know, your organizational, you know, direction in terms of what things are going to go in and what the impact is to your docs and to your revenue. I mean, I think those are all pieces that you have to understand and then modify your direction. I think in any organization, we all come from large entities. There's complex and competing priorities that aren't related to this, you know, such as putting in a new EMR or other systems or other organizational efforts that have to be recognized. And again, the changing regulatory landscapes, I mean, you know, who knows what's going to happen, you know, several months from now with a new, you know, administrative change and where that's going to go. So, I mean, all of this is hard things to get your hands around. And I still struggle with myself is interoperability issues. You know, we talk about data and getting data, but really there is a struggle with that. I mean, if you have a large system like Epic, you know, that we're doing, it solves a lot of those issues for you, but you still have kind of organizations that don't have access to that type of technology. And then just the technology in general, there is a ton of vendors popping up all over in this space that are population health vendors. There's a lot of buyouts and consolidations going on. You know, just recently, you know, you looked at Wellcentive was purchased by Philips and Evolent bought Valence. I mean, it just constantly just moves into that direction. And they're trying to be all things to all people. So I think that trying to manage all of those different pieces and stay in the right direction is the challenge for all of us.
Very good. Well, we're going to move along here in the interest of time and get some comments on each of these questions if we can. Michael, let me go with you on this question about bundled payments. Talk a little bit about bundled payments, episodes of care, and distributed risks and payments, and the idea that transitions of care are especially important in value-based care. How are you managing these for efficient handoff? So anywhere you want to jump in there.
So I'm probably the last person to talk about this of everybody else on this group. But like I said,
I have faith in you.
Yeah, it'll be brief. So like I said earlier, within Ohio, we haven't really seen a huge shift in our reimbursement models and how we're changing. So we are doing some bundle payments, what I'll call just dipping the toe into that around cabbage and some, you know, valve replacement, some other things, just to see how we're performing. And I think we're doing well, but really that's the extent of what we are doing right now from a change in reimbursement. Okay. I would like to go back to I think one thing that Renee said is really important, and she started with that about the difficult part. And yes, the technology is difficult. And there's other components that are difficult, but it's explaining the why. The why is the most difficult. I mean, organizations are humming along. They're successful. They're successfully from a service perspective, from a quality perspective, from a financial perspective. And then, like at OhioHealth, we have 28,000 associates. Why are we changing how we are doing business? Why are we doing this? And that's still a message that we struggle with. We see it coming down the road, but that why and that understanding is really what we're seeing as the most difficult part. I think that's really important because we get caught up a lot in terms of the technical issues, but Renee was on point when she brought that up first, is that the communication of why we're doing this is extremely, extremely complicated.
Anybody want to jump in on this question? No? Okay. I don't blame you. All right.
Thanks a lot, guys.
Let's go with Kyle for this next one. What specifically is the CIO's role in this transition, to lead, to follow, or a combination of both? And some sub-questions are, how do you make sure the move doesn't become an IT project, which is every CIO's nightmare? Could you see a scenario in which the CIO says, we're not ready for this yet? And then talk about budgeting. How do you get the money you need for the tools? So anywhere you want to jump in there, Kyle.
Okay. So first and foremost, I'd say if this hasn't happened in your organization yet, pushing to have your organizational strategy tied to the IS strategy. Those things should be really a partnership. Actually, organizational strategy equals IS strategy, and that's the way it really has to be, you know, moving forward. We've talked a lot on this call about, you know, operational ownership of projects and efforts. So, you know, that's really how this doesn't become IT, and I think there's been a real movement for, you know, probably the last 5 years for things to shift from being IT projects to, you know, operationally led, and I see it more as a dyad where it's a partnership between IT and the operational unit, but the operational unit's really taking the lead with the organization. If you have a good plan and strategy and roadmap, I think it's going to be fairly easy, maybe not something that the organization will like, but why we might not be ready for something yet, because, you know, a lot of the technologies we're looking at are building blocks on one another, and they're definitely foundational things like, you know, EMRs and all of those things that have, you know, the transactional data, and then on top of that, you can build analytics, you can build population health, you can build telemedicine, you can build, you know, a number of things, but there is a method to the madness here, and having a good plan and strategy really helps you talk about that. And same thing with budgeting. If you've got a good 3 to 5 year plan and set the budget forth by, you know, to follow, you know, really that plan, that really allows the organization to plan and contemplate, you know, for the future years. And I'm not saying it's easy, because we're all living with, you know, less reimbursement, but I think the more we help our organization see what's coming and what we have to plan for and engage in the dialogue in that, you know, that helps us be effective CIOs in our organization and helps the organization with the transition.
Very good. Okay, Renee, is it better to think of the move to value-based care as a big bang or slow transition or some sort of combination?
Well, I think, you know, for big bang, you could be brave and move the organization very quickly to that. I think that, you know, that is a strategy. I don't necessarily know that that's the most effective one, most effective method. There is some risk on the reimbursement. If you don't correctly assess it, you could penalize yourself. You also might, again, I'll go back to the buy-in piece of it. You need the buy-in from the physicians and administration, and again, I'll go back to physician fatigue. If you're constantly pushing this thing along, it could have a negative, you know, impact on you. And you can get ahead of the regulatory requirements and risk misinterpretation. I mean, even when MACRA came out last week and everybody was relieved, it was like, yay, but yet there was things in that regulation that said, well, we'll decide this later on, we'll decide that later on. So I think managing that is pretty complex, and so if you just rush down that road, you could take the risk of getting ahead of yourself. You know, on the slow, if you take it slow, you have a little bit more time to fully understand, and you can, you know, follow a strategy, move at a little bit more of a calculated pace. You can get a more full picture of the regulatory components being worked out to the best that you can. You can create opportunities for the education and the buy-in and cooperation. On the downside of it, if you go too slow, you'll miss the opportunity for increased revenue on the risk-based models, so you have to kind of weigh that all out. And the other thing is network loss. So, you know, if you are not moving in a direction that's, you know, quick enough and risk-based enough, you know, your network loss. I mean, the key behind all of this is who is your network. And if you can't produce for them or get them where they need to be, they'll seek opportunities elsewhere. So.
Very good. All right. I think we're going to wrap it up here. I just want to get Fred to jump in at the end here. Fred, as our sort of sponsor and host, if you want to just give your thoughts, your final thoughts, final advice to those on the call today and those who will listen to this in the future.
Sure. Well, first of all, thank you, everyone. This was a great panel and it was a great discussion. I very much enjoyed it. And I think we talked about some very important things. I think it's very important to realize there was a question that I actually didn't participate, but it's very important to understand, you know, what's the most difficult part of going into this value-based environment, and the fact is that there's still a lot of people who are new to this, and in some ways this is a paradigm shift, right, for a lot of organizations. And the worst part is usually paradigm shifts happen, and you just in that part of the world, and that's what that's where you're going to live in. Now organizations are having to straddle the line. They have to be in the fee-based and still be in the value-based, and they have to do both. So having the ability to do both is not an easy thing. But I think this is where healthcare, like many other domains, have to take advantage of the data and the resources that are available to help them with that. And that's going to take time. But I think we've come a long way from 4 or 5 years ago, or even back when we used to call it pay for performance, not necessarily a value-based environment. So, but I think that there are tools out there that can help organizations get to where they need to be able to support their population better in a value-based model. Having said that, I want to thank everyone for their participation. This was great.
And I want to, as well, I'd like to thank everyone. We're just about out of time, so when you close out your window, if you would take a moment to answer our post-event survey, we'd appreciate that. I want to thank our panel, Kyle Johnson, Michael Elley, Renee Broadbent, and Fred Rahmanian, and also Geneia very much for sponsoring this event and making it possible. You receive an email when our archive recording of today's event has been posted to our YouTube channel. For those of you with the CHIME CHCIO certification, attending our webinars gets you 1 CEU, so let CHIME know you were here, and if you've asked us to do so, we certainly will. To get a webinar like this produced on a topic of your choice, contact Nancy Wilcox. And if you need a certificate of attendance for another CEU program, you can use the final slide in this deck. And of course, go to our website to see our upcoming schedule of events. So with that, I again want to thank the audience. I want to thank our panel and Geneia, and everybody have a wonderful day. Thank you.